afternoon. Yes, I want to speak a bit of the role of time on ischemic stroke. And of course, time is very important for a stroke because if we don't open the artery, the infarct will grow and grow and finally produce a very severe sequela for the patient. So we think that the infarct growth in humans is exponential, and in 2006 we even were able to determine the number of neurons, of synapses and kilometers of myelin fibers that can be damaged by time with an occlusion of a large artery in the brain. And the average infarct growth was estimated at about 5.4 millimeters per hour. And why so important, the infarct growth and the infarct size? What really matters is the status of the patient. And we know that the infarct volume is a pivotal biomarker of the results of the reperfusion therapies. And this is even more important in older people, that we can see that with very small infarct volumes, their probabilities of having a good clinical outcome decrease significantly. So infarct volume is very important, and that, we need to have small infarctions. So is just this a matter of time? Well, we think no. This is an analysis that we make in all code strokes in Catalonia in one and a half year, and we divided them by every 30 minutes from symptoms onset till 6 hours. And as you can see, the aspects score, there is the score that determines the degree of extension of the ischemic lesion in the CT scan, decrease a bit, especially with the aspects of 10, decrease progressively, but this decrease is not very deep. And actually, if we fix on the 5, the aspects of 5, which is the theoretical limitation for thrombectomy in stroke patients, we see that in the first 6 hours, there is no there are very few patients with aspects below 5, and this is similar in the first 3 hours and the next 3 hours. So this is again showing this beautiful manuscript where they associate time from symptoms onset with volume in the MRI of the infarct, and you can see there is a high variability of infarct volume depending on time. The authors weren't even able to determine an association between time and diffusion lesion volume, and they make an estimation of the infarct, the velocity of the infarct growth, and they saw that again there is a high variability. The average infarct growth was 12, so the double from the paper I showed you before. And what is very important is that they found there was a correlation with collaterals. So collateral circulation, leptomeningeal circulation, is a very important issue in stroke. When we have a large vessel occlusion, the collateral circulation compensates this area of ischemia, and we know that the degree of collateral circulation is an important determinant of the success of the treatment, and predicts hemorrhage. It correlates with the infarct volume, the basal infarct volume, and it also correlates with, it's an independent predictor of good functional outcome and of infarct volume, of course. So collaterals are very important, and we were even able to demonstrate that the effect of time on recanalization is is compensated by collaterals. If you here, if you have good collaterals, the curve is the curve is very plain. But if you have bad collaterals, the influence of time on recanalization is very important. Collaterals are important, but of course the quickness of the recanalization is very important too, as was already demonstrated in 2012 by Dr. Masihi here. And later, this collaboration of investigators were able to show this graph when we see how decreases the probability of good outcome of our patients when according to time. And they determined that for each 30 minutes to reperfusion, there was a decrease of 10% on favorable outcome. So time is important too, of course. And again, in the Hermes meta-analysis of all thrombectomy trials, again, they show that the time to recanalization was associated with the outcome of the patients. And this is the same curve that we saw before in this other group of patients. So time is very important, but it's not only, we can fix a bit more and think a bit more. In Revascat trial, the trial that of thrombectomy done in Catalonia, we analyze again the effect of time and recanalization in the outcome of the patients. But we divided this curve in two. So we see the effect of time from onset to imaging and from imaging to recanalization. And you can see that the real effect on the outcome of the patient is from imaging to recanalization. I'm not saying that the first time is not important, of course. But what happens is that when you do the imaging, you discard those patients that already have a very big infarction. And in the patients that you treat, then time to recanalization is very important. But if we are able to reduce this time, the time from onset to imaging, we will increase the number of candidates to thrombectomy. So we all people that are interested in a stroke have the obligation to reduce as much as possible our metrics to treat our patients as soon as possible. And this implies in the pre-hospital setting having a good network to transfer our patients with blood vessel occlusions the quicker the possible to a place where they can receive the best treatment, that is thrombectomy. And also in the hospital setting, we have to try to reduce our times as much as possible. In our hospital, we have established the angio code. That means that patients who are very, they have the high probability of having a large vessel occlusion and are below 6 hours are transferred directly to the angio suite. And with this, we have reduced dramatically our door-to groin times. And reducing our door-to groin times, we also reduce our symptoms to recanalization time. And even if in the small number of this paper, we weren't able to demonstrate the clinical impact globally, but we almost doubled the number of patients who experience a dramatic clinical improvement. That is, their NIHSS was reduced by more than 10 points or below 2 at the end. So it's very important to reduce times, and everybody has a possibility to do it in their own field. In the pre-hospital, during the transfer of the patient from the ER to the angio suite, and during the procedure too. But we are not the only ones who transfer the patients to the angio suite directly. And in this group, they also show that the reductions of time are very, very important if you have this way of managing patients. So what happens when we put the patient after the puncture? Does this infarct growth continues or is stopped? Well, we know that about 30% of patients experience a significant infarct growth despite complete recanalization. And in this work, the authors saw that it was not so important, the duration of the procedure, but they found as predictor of significant infarct growth the lack of IV TPA treatment and the lack of use and the use of first-generation devices compared to stent retrievers, probably because these two variables are associated with complete recanalizations. Again, this other group looked for predictors of infarct growth and saw that the main predictor of infarct growth is the absence of recanalization, but they also saw that the collateral circulation, again, is a very important predictor for the growth of the infarct. And, of course, the degree of recanalization. So again, good collaterals and a small diffusion volume that probably is associated with good collaterals were predictors of no growth, but the most strong predictor of absence of infarct growth was the complete recanalization. So, and this again is the curve that I showed you so many times before, the relation of onset to treatment time and good outcome. These authors, this is the global of the series, that's the typical curve, but they divide it between the degree of recanalization. And you can see that the time is very important in patients with partial recanalization, but it's mild when you think you reach a TK2B or a TK3. So time is important, but also collaterals, and very important that you reach a complete recanalization. This influence in the infarct volume of your patient and the prognosis. And finally, 2 slides about DOWN. DOWN is a clinical trial that will probably change our work in the future. And they selected patients between 6 and 24 hours from symptoms onset with great vessel occlusion who had mismatch between the clinical deficit and the infarct. They established this selection method, and you can see that younger patients could have a higher infarct volume than older patients. And this is one example. You can see here this infarct volume of 50. It's a big infarct volume, but it was a young patient with a very severe stroke, so this patient was treated in DOWN. And what did they found? Well, they found that thrombectomy improves the clinical outcome of stroke patients in all type of stroke onset, witness or witness, and you can see it better in this slide. Between 6 to 12 hours, thrombectomy was significantly better than control, and maybe it was still better between 12 to 24 hours, that you can see the rate of patients with good outcome as compared with those with bad outcome. So DOWN should make us think that time is important, but not so important, and we should try to reduce our metrics and to do things better, but to treat our patients very quick. But we should not think about time like a limitation, and think better about the hemodynamically and tissue windows to select patients for acute stroke treatments. Thank you very much.
Thank you very much. My question is, do you think collaterals may play the same role in anterior circulation stroke as in posterior circulation stroke, or is there a difference?
Well, actually, in posterior circulation stroke, there are very few studies looking for collaterals, so we don't know the importance in this setting, but probably the cerebellum has good collaterals. So for this, for the infarct of the cerebellum is important, but in the mainstream there is no collateral. So in this case, the occlusion of a basilar the influence of collaterals maybe is not so important, but we don't have the information.